Hi friends, welcome back to All or None Law. Today I'm going to talk about gastroesophageal reflux disease in pediatric patients. So this is an important topic for your pediatric board examinations like a massive PCH examination, and even it is helpful for your USMLE examination and Australian Medical Council examination and IFORM or MCCEE, that is a Canadian Medical Council examination. Before starting this, I would request you to subscribe to our channel. Please subscribe to our channel. We need your subscription badly. Let me start with this. Briefly, I will discuss about this gastroesophageal reflux disease or GERD. The GERD, the GER, is defined as the passage of the gastric content into the esophagus. So, GER is a very common in term and the preterm neonates. Very large majority of infants exhibits no signs of clinical compromise and hence do not warrant specific treatment versus infants who experience feeding difficulties, poor weight gain, failure to thrive, etc. as direct result of reflux. Okay, so the gastroesophageal reflux is a GER, is a gastroesophageal reflux disease, is a GERD. For infants who have persistent spitting up, care must be taken to ensure that there is no true underlying pathology as a cause. Apnea and GR are common occurrences in the premature infants, but studies have shown no temporal relationship between the two. The risk factors are congenital diaphragmatic hernia, esophageal atresia repair, gastroschisis, omphalocele, short bowel syndrome, bronchopulmonary dysplasia, and neurological deficits. So these are the risk factors. Okay, differential diagnosis is a differential diagnosis for GER should include GI tract anatomic abnormalities, esophageal webs or stenosis, duodenal webs or stenosis, malformation, malrotation, gastric outlet obstruction, inborn errors of metabolism, renal dysfunctions, neurological deficits, bronchopulmonary dysplasia. Sometimes a mother brings the child or a baby, what do you call it, with an infant with the signs of asthma or okay. So sometimes this is very important. One of the cause for this asthma could be gastroesophageal reflux disease, and the other thing is they will have a persistent cough, so this can be a cause also. GERD, the GERD causes a cough. Okay, so clinical presentation: dysphagia or odynophagia, then arching of the back with the feet, irritability, failure to thrive, and hematemesis. So these are the usual. Even can be cough is there, even can be breathing problems, right? So sometimes it's an indirect presentation of GERD. The management is very important topic here. Initial management should be aimed at non-pharmacological maneuver. That's very important. So positioning of the infant, you should direct the mother how to position the infant during the feeding. Positioning of the infant with the head of the bed elevated, very important. Changing the rate of feeding, slow rate of bolus feeds to 60 to 90 minutes. Feeding less volume more frequently, very important. So non-pharmacological treatment is the best, is the starting option for patients with a GERD in a pediatric patients. Consider thickening of the feeds with the commercially available thickeners. Thickeners are commercially available. You can mix it and it goes in the stomach and they become as thick, not like a stones. It's just gonna thick and it helps to remain the food in the what you call in the stomach. Discontinuation of the caffeine for apnea of prematurity may ameliorate symptoms of GERD. Pharmacological therapy can be used if the above measure fails, but data on efficacy in this patient population are very limited. Very good. This is because data has shown no significant change in after starting with the pharmacotherapy. So the drugs what you can start with is the use of H2 blockers or PPI to decrease gastric acid release have been reported with the mixed results. Use of promotality agents is not advocated because of the potentially serious side effects. Example: Parkinsonian reaction, tardive dyskinesia with the use of metoclopramide may not be reversible. Infants with severe symptoms as above GERD. Infants with the GERD, what do you call GERD, often have two esophagitis or a gastritis and have been shown to benefit from a gastric acid reduction. Okay, sorry. Oh, sorry. Okay. Surgical intervention with fundoplication may be considered for infants who fail to respond to the pharmacological therapy and continue to display the signs of what you call GERD. Okay guys, thank you so much for watching my video on GERD. Thank you so much, and please tell your friends to subscribe, and you please do not forget to subscribe. You can tell your friends through the Facebook, email or Twitter account, whichever is convenient to you. Okay guys, thank you so much for watching my video. Take